Thank you for joining me for this episode. Today we're talking with Dr. Cecelia Koetting, and we're going to be speaking about shedding light in your practice in 2026 with IPL and low-level light on the OI show. Are you finding that being a business owner in optometry is getting tougher and tougher every single year? Here's the tough truth. For every hour that we spend with patients, we spend 2 hours on administrative work, from charting, working with our team for prior authorizations, inbox messages, and so forth. In fact, up to 70% of our team's time is non-clinical, and patients are feeling this disconnect. I've worked with virtual staffing for over 10 years, and when we started implementing virtual team members into our practice, it changed everything. And then when we found team, everything changed. They helped us choose and support the right people. Now a virtual team handles documentation, prior authorizations, patient communication, phone calls, and scheduling. For more time with your patients, more energy for your team, visit hireteam.com. That's HIRETEEM.com, hireteam.com to get you back in your practice in 2026. Thank you again for joining us today. I'm delighted to be joined by my sister with a slightly different name, Dr. Cecelia Koetting, and she pronounces her name a little bit incorrectly. It's supposed to be Koetting, but if you don't know, we have very similar names, and I think that we're related way back, and our names got changed at Ellis Island
Somewhere
or
it got messed
something,
up. Someone
something.
messed it up.
But so we always get to joke about. I call her my sister. I don't know if
I
she
love it. I
claims
love it.
me, but it's delightful to have you on the podcast again. Thanks for hanging out
It's
with me.
great to be here. No, I will claim you. I don't claim my real brother, but I love it. I'm
Yeah.
excited to be here.
Yeah, we have had you on the podcast before, but for
Yeah.
people who may not remember, tell us where you practice and what you like to do for fun in optometry.
Absolutely. So currently, I am at the University of Colorado School of Medicine. So I'm in Denver, Colorado, practicing. I'm trying to remember when I was on the show. I don't know if I was with the university at that point, but I've been with the university for almost 3 years at this point. So really enjoying it. What do I like to do when I'm not doing optometry? Is that the
Well,
question?
sure, yes,
Or
but
what do I
also,
like in
what do
optometry?
you like in optometry?
I love lots of things in optometry. My life currently focuses mainly on ocular surface disease, cornea, more of those cases that no one really wants. But I love them. I think they're a little bit of a mystery that you get to put together and solve. But I still do a fair amount of neuro, and you know what? You can find me talking about all sorts of emergencies because those definitely keep our days interesting, a little spicy.
Yeah,
Yeah.
absolutely. So I want to shed a light on some of the ocular surface disease things and talk about these light therapies. And I know that you've lectured on this before, so hoping to dig deep into your brain along this. In our practice, and I know in many practices of our listeners, they're bringing in IPL and low-level light and radio frequencies and thermal pulsations and procedures, fortunately, has become a bigger part of what we're doing in eye care, which serves to provide some anti-inflammatory effects as well as increased gland flow. We have pharmaceuticals on that. You're an expert, a wizard in pharmaceuticals as well. But the procedural approach, in places that are hippieville, like Denver and like Seattle, they tend to like kick in. They like that, right? They like it
Yeah.
in addition to drugs.
Yeah.
So, would you kind of walk us through the state of the union of light therapy? And I particularly want to dig into low light therapy, but why don't you give us a broad horizon of where you see us at right now as we're in 2026?
So I feel like we are actually at a pretty good spot in 2026 in respects to photobiomodulation. And when I say that, that's the lovely catchword for when we talk about low light level therapy and IPL. Radio frequency is actually not a photobiomodulation. It's got its own separate
Hmm.
thing that it's doing. But I think that the uptick in the usage of this has increased significantly in the last 5 years. But I think that it's still a little bit of where do we put these things, right? By uptick, more of us have it. I don't know necessarily that more of us are using it. I think that those of us who are using it, some of us are struggling with when do we do what? And you and I were talking a little bit about this before. Um,
Mhm.
I'd like to see this be something that we as optometrists kind of own. Yes, it's aesthetics, but it's also part of the eye, and it actually makes a huge difference for our patients, not only from just a true traditional dry eye and meibomian gland, but when we start looking at things like TriLift and Tixel and all of these other things that address the eyelids and their positioning that leads to ocular surface disease and dry eye. I think that these are non-invasive ways that we can really make a huge impact on our patients.
Hmm. Yeah, agreed. And IPL is particularly on low level light is certainly not new in dermatology, in
Correct.
the eye care space, as well as other areas of medicine. And share with us, you're aware that particularly low-level light has been utilized post-surgery and other
Yeah.
sorts of things. And what are you understanding that it is doing in those systemic situations or
Yeah.
orthopedic situations?
And that's another place that it's been used for years. And when we look at PRP, PRP is the same idea. It's been used
Hmm.
for injections into not just develop collagen for aesthetics purposes, right? But it's
Hmm.
also been used for joints where there is inflammation. Same thing
Hmm.
with low light level therapy. It's been used post-surgical or perioperatively, or even when there's injury to soft tissue and muscle. And my understanding is that aids in healing, regeneration, and a quicker recovery in those situations. And honestly, when I had knee surgery, now that what I know, I'm like, why wasn't my doctor having me do that? I would love to have added that in so I could have recovered a little bit quicker. But that's kind of my understanding is the broad 30,000 foot view is it's aiding in that healing and that inflammatory response.
Yeah. So my understanding is that low level light it actually dates way back. I think some of the early days, even back to the 1960s. In the
Mhm.
1990s, NASA researchers found that it could be beneficial and maybe could help astronauts. And so I think they sent it up to the space
Yeah, I
station and they
remember that.
utilized it.
Yeah,
Yeah, so it began a long time ago, and although NASA didn't work to develop it, it really kind of helped catapult it as being like much more than a pseudoscience, right? We think
right.
about these
Yeah,
things from the perspective of let's shine a light on something, right? That seems so crazy that it would work. But you use the word photobiomodulation, and that's a fancy term that I'd like to
I
say for
like it.
patients. I tell them I say that word so they think I'm smart. But what is going on there? What do you understand photobiomodulation to be?
So my understanding of photobiomodulation is utilizing exposure of non-thermal red and infrared light. So certain, remember going back to our wavelengths and our different levels of light that we have, the UV, green,
Hmm.
our YAG, our all of these different things, right? And so specifically red and infrared light is being used therapeutic benefits stimulate healing, regeneration, protecting risk of injury or degradation or death of those cells themselves. But specifically, it's just talking about the discipline of utilizing that light on living
Hmm.
organisms and then the biological processes that are part of that.
Yeah, we see a lot of this benefit, particularly in our dry eye patients, because
Yes.
we see, we look at my biography and we're like, are the glands dead? And
Mhm.
now I think we're starting to realize that they're probably not dead. They're just not showing up as well.
Right.
And I remember when I want to say he's my mentor, and I think he would have said he was my mentor, Art Epstein, who may he rest in peace, spoke about he thinks he's seeing glands that are coming back, and I'm like, Art, you're crazy, right? But
It's
now,
hard, but you can get a little bit.
years later, we're starting to see that that may be the case. I had Andrew Pucker on the podcast, and Andrew showed that when he imaged meibomian glands with an OCT imaging device versus the imaging device most of us use with the keratograph or with some of the other infrared type of technologies, that the glands actually looked better with this OCT type of imaging. And so maybe the glands actually are there and are functioning. And so maybe it's just they're not functioning well. And that's where
Right.
I think this photobiomodulations, as you really kind of stated it, and how I explain it to my patients is we're working to try to improve the gland function for
Yes.
meibomian glands. And then I say, and remember back in biology where the mitochondria is the powerhouse of the cell, and we're stimulating it so it produces more ATP. And then they're like, oh yeah, the powerhouse of the cell, right? They start to
I
remember
love it.
that. And if I remember from having read a little bit about this, it also works on something key that we don't talk about in optometry very much, is the release of nitric oxide and reducing of oxidative stress. And I think that may be an area that we undervalue and don't understand all that well. And that's for another podcast of how impactful that is. My naturopath doctor actually was releasing some she was doing some treatments on me where she was giving me infusions of O3, which was a heavy inundated, which so that it could go into my systemic system and
Mhm.
work to negate a lot of this nitric oxide effect that was going on. And so there's something there that I think we're going to have to dive into a little bit more in the future. But low level light, to some degree, is really working in that arena. So
Yeah.
if
Yeah,
nothing
that's my
else,
understanding as well as the two
mhm,
main mechanisms that we understand are the mitochondria that you were talking about and the nitric oxide and dealing with oxidative
mhm,
stress. There's also some looking at as far as like improvement of growth factor release, some changes in gene regulation
yeah,
that
hmm
also are supposed to be helping. So the hard part is a lot of these things are really hard to prove, which is why I know I understand why a lot of people are like, is it really doing anything? And it's like,
yeah,
yes, but I mean, in as much as we can with any treatment, it's why it's always talked about the theoretical mechanism of action,
yeah.
even when we're talking about pharmaceuticals.
Yeah. So, well, speaking about pharmaceuticals, how do we know a pharmaceutical? Let's just briefly talk about what has to happen in order for a pharmaceutical to get approved by the FDA. It has
Yeah.
to have a statistical significant improvement. Many a times, I don't know that I would clinically always see those improvements, particularly in some patients. Now, I use pharmaceuticals on, the vast majority of my patients because we do believe that's an important component to it. But if you haven't seen a major improvement with these light therapies, that doesn't mean it's not working. It may statistically be doing it. But I think the studies that I've read have shown more than a statistical significant improvement, and they're showing clinically significant improvements that many of our patients have shown, particularly in dry eye and with low-level light, well, and IPL
Well, I
chalazion,
was going to
right?
say IPL, we've got plenty of studies at this point,
hmm
and we even have an FDA approved device. We have
hmm
the Toyos protocol, which is FDA approved, right? So all of
hmm
these things that are backed by science. Now, low light level therapy with the red light, that one, there I feel like we've got significantly less when it comes to eyes and dry eye ocular surface disease. There's some other studies looking at use for myopia and for even for macula. Um, and it's not that the data's not the potential's not there. The data's just not, I don't feel strong enough to really necessarily not to not convince me because I will jump on board and try things and see where we can go. But I understand for some of our colleagues, they may be a little bit more hesitant just because they don't feel like that volume of data is there.
hmm The nice thing about it is it's not a large barrier to entry, right? Where some of the other treatments may be 60, 70, 80, 90, $110,000 to bring
Or
into your
more.
office.
Yeah.
Low level light tends to be considerably cheaper.
Yeah.
Now, that begs the question is how cheap can you go? Do you have a perspective on can we just get this off Amazon?
Yeah, so no, you shouldn't buy this off Temu, Amazon, Shein. Probably not where I'm going to go for this. Do I have my own personal facial low light level therapy that I use at home? Yes, but I don't know that I'm going to go charging people to utilize it in my clinic.
Yeah.
And this is where I feel like it gets a little bit difficult and a little sticky, right? We do have some reputable companies that are actually coming out with product and with devices that we can use. And I think that that's probably where I would hone in. And the reason I say that is because with the lights themselves, right? There's difference in the quality, making sure is the light getting to the tissue that you want it to, or is it diffusing out and not getting to where it should be, and is it actually hitting the levels that they say? Now, again, I don't have one of these devices in my clinic. You do.
Hmm.
So I haven't, to be honest, I haven't dived into say, okay, I need to make sure it's got XYZ. Do you have anything
No.
that you know of that are like, these are the things to look for?
Yeah, so some of the big things is number one is the calibration of the light and the infrared. So we you can't see infrared, so these devices that you're getting offline, you don't necessarily know how much.
No.
You can see that it looks red to say that it is red light therapy. So when we're buying something, we're utilizing something that has a calibration. We know the intensity of it, and you can control the intensity. And a lot of times, I think what we're not doing is we're not using a high enough intensity, particularly
Right.
with the off the rack ones. My first in-office low-level light, and I've had two of them, my second one can get a lot hotter. I mean, you're sitting underneath that light and you can be sweating. You can get the patient being like, feeling like they're getting
Now it's turned into a
really hot, right?
sauna.
And so that's a really high intensity. And so we have to think about that doesn't mean that it's penetrating deeper. It's just a higher intensity at the
Right.
depth. And
Well, and it
that's where
shouldn't
the
matter. The color is the color, right? The infrared, the red,
Mhm.
that is its wavelength. That's not
Yeah,
going to change how deep it's penetrating, but you're absolutely
exactly.
correct.
Yeah.
The intensity and what's actually going to make it to their, yeah,
Yeah. So, in a lot of aesthetics clinics, they might use a blue light because it's a more surface layer treatment.
yeah. My
So when I
understanding
do
is more for like
hmm
rosacea and
acne and
acne.
rosacea.
Yeah,
Yep.
yeah.
Yep. So in my clinic, what I do is I do an infrared and a pink light because then I'm getting red and blues, and that
Okay.
way I'm penetrating both in the deeper and this more superficial. So
Yeah,
I'm giving them a little bit of an aesthetic, but still penetrating deep enough with the pink to be able to get to the layers that are going to be helpful for the MGD component, and then
yeah,
utilizing the infrared. And there's variability in the study as to how often or what's the course of treatment. There's some studies that show that a singular treatment for a chalazion can be beneficial. I haven't seen a singular treatment. We might see it after two or three,
hmm,
but that's something that's not invasive. And you can
right,
say to somebody, hey, rather than us sending you for surgery right now, here's an
right.
alternative that we could do. And
Now I'll
usually
use
this,
my IPL for that.
sure.
Again, it's what I've got, right? But my IPL does have a 450, which puts
Hmm.
us onto that blue wavelength, and then I'll also
Hmm.
hit it with the other one to kind of really shrink
Yep.
that sucker up.
Yep, and we'll do a similar sort of thing and hit it with both IPL and then have them sit under the low level light.
Yeah,
Or I've had some kids and we may not have them want to do IPL or we may not feel comfortable with it. That's
right.
for the FDA clearance of where it's allowed, and we're delving into a lot of different space, even doing it with
Yeah,
a chalazion. So
yeah,
I'm not too worried about it, but we tend to not do IPL on anybody under 14, 15, 16, and kind of we're
yeah.
gauging that.
And I
So
just don't
kids,
have any of those patients in
yeah.
my clinic, so me either.
Yeah, yeah. So this is a really key component, I think, of looking at the different strategies in the future. And I guess one of the other components is where would we use one of them and where would we not? So let
Right.
me ask you this is if you had an MGD patient who also had some inflammation and said, I'm going on pharmaceuticals, and they had telangiectasia, that's for you a slam dunk. You're going to do IPL on them, right?
Absolutely.
But what if they didn't have telangiectasia? Would you still do IPL on them?
Yeah.
Hmm. What would you
Yeah.
expect? Would you expect a difference from them? What would you expect? Would you expect the same outcome from a telangiectatic versus a non-telangiectatic patient?
Um, I to an extent, right? I think telangiectasia is probably a more downstream effect,
Hmm.
or more chronic patient. Maybe this is somebody who's doesn't have telangiectasia, not because they don't have it, but because they maybe haven't had it as long.
Right?
And I think there's just a lot of things you have to, there's a lot of nuances. We know this. There's a lot of nuances, but that's why I don't ever say I have a hard and fast. I have to look at each patient as a whole. And we know that if I've got any level of meibomian gland dysfunction or poor meibum expression or quality, the longer I leave it, the longer it's going to create bigger problems, gland atrophy, truncation, that telangiectasia that may be there. But it wouldn't, I don't have, I would not do it in a patient who doesn't have just one specific component
Sure.
to it. Does
Hmm.
that make sense?
Absolutely. Where are you at with expression after? Do you do
Always.
expression afterwards?
I
Hmm.
always do a exfoliation and then an expression.
Yeah. Specifically, tell me how you do those things.
So, because I'm at a university and we can't do thermo expression currently, because of bureaucracy, because it's fun. My options currently are that I will have my patient have sit with a one of the disposable heat masks because I don't have I don't have to worry about keeping it clean, whatnot. So we do a disposable heat mask for 15 minutes. I then go through and do blepharoexfoliation with a new lids, and then I go through and I express manually.
Hmm.
In a
Uh,
perfect world, I would probably have pull in any one of the devices to save myself a little time.
are you doing IPL? Did you say
Oh,
IPL?
IPL and then that. Yeah.
And
So I
then
always
and
do the
then
IPL first, same day, and then I will express immediately after. And then we do 3 sessions. So if it's a new patient who's having IPL, we'll do 3 sessions, usually scheduled about 3 to 4 weeks apart. And I will do the heat mask and the manual expression and cleaning at each one of the visits.
hmm. And what device do you use in clinic?
So our oculoplastics one, I got the long straw, I got the short straw. So we have a Rohr Aesthetics, ROHR. So not something you're going to see in eye care, and the reason is because it's got Fraxel and other things to it, of which the oculoplastics wanted to be able to have the access to. So
Hmm.
it's a little bit different. It's a nuanced little beast, but it works well. It still works really well.
Hmm.
I've had others in clinic, in previous clinics, but this guy's pulling its weight. So that's all
Yeah.
I can ask.
Why do you think it is that we have so much variability in protocols? And I want to hear your take on this. I have a guess as to what it is, but sometimes it's 3 treatments, sometimes it's 4, sometimes it's once a month, sometimes it's every 2 weeks. But there's such variability. And then the other thing you see within the studies is the joules that are being used. And sometimes in a study, they're like, okay, we're going to use this joule amount. But in clinical practice, depending on the Fitzpatrick, we may use a little bit more, a little bit
Right.
less, and so forth. What do you think?
So I think it's who taught you, right? Some of that's going to be
Hmm.
it. Like where did you learn it? Who did you pick it up from? Who have you had conversations with? And then
Yeah.
it's also a little bit of what have you learned in clinic? And so I know for me, why am I doing 3, not 4? Well, because when I was learning and figuring it out and trying to make sure I felt comfortable with what I was doing and selling because it's out of pocket, Um, do I think I need three? Do I think I need four? And I kind of settled on most patients would respond well, and we were doing very well when I did the um, comparison of pre-treatment to post-treatment exam findings, including tear osmolarity, speed, expression, my MIGLs, my MGYLS, and just looking at the before and after photos. Is four incorrect? No, I still have patients, like my rosatic patients, my patients who have really awful MGD and a lot of atrophy and truncation. We still do four. And then I'm debating, when I do my follow-ups as far as like how often do they need to have it redone? My rosacea patients, I tell them, hey, you're going to have this every 3 to 6 months. And we're gonna do this once every 3 to 6 months, but some other patients we may be able to go out to doing it once a year. And it's a lot of trial and error. But I think that's probably in part, I know for me why I've kind of settled in, but I think that's probably also why some of our colleagues, you and I think do it a little bit differently, but I think that's part of it is just experience and finding out what works for us versus maybe what's the published protocol.
Yeah. Yeah. Well, when we first brought in IPL to our office back 6 years ago, um, we read every paper, and at the time there was like 170 of them. And between
Just a few.
myself and my two residents, we each took like 30, and then we looked at protocols and we looked at
Yeah.
what the outcomes were and what did we want to achieve. That's not how most people do it, and that's
Yeah.
okay. We're very nerdy. Um, but the variability was just really interesting. And then one of the other interesting things was the difference in the joules. And what I've
Yeah.
now since discovered is because I've had two different IPLs. One of them has been a cooled system, which was the Luminous OptiLight system. And then our
Yeah.
second one, the one we use most often now, we still have two of them at our two different offices, but our main office uses the MD Elite system, which isn't cooled.
Yeah.
And so the jewels that
Do
we
you have to
have
use
to
that
use,
transduction jelly with the MD Elite?
we use jelly with both of them. Yeah.
Okay.
Um, and but with the cooled, and what was happening was the device that Lumines put out, they use cooling because in some patients that were in the aesthetics is they would do laser hair removal, and so it
Mhm.
wasn't laser, but they would really have to crank things up really
Yeah.
high, and so they would need to cool everything in the process. If you take that cooling off, you can actually reduce the intensity quite a bit, and
Mhm.
then our patients hardly feel it at all, but we're still
Yeah.
getting similar outcomes. And so if you don't explain that in a study and you have two different devices that have
The
like a 10
nuances.
a 10 difference in the joules, and then you're seeing some patients for four, some patients for two, some patients for three, it can be really confusing to our colleagues. And I think that's part of the confusion that has happened. We also did something kind of interesting that we're publishing as a poster at the Global Specialty Lens Symposium, which is upcoming for this podcast, but will probably have happened by the time that we're actually posting it, where we looked at our outcomes from our 4 visits versus
Mhm.
our 5 visits. And we mostly do
Yeah. What'd you
five
find?
IPLs.
Okay.
We looked at meibomian glands yielding liquid secretions, and we do not do manual expression. So what we were looking at is how many glands flow
Hmm.
post-expression. And on average, it was 0.75 glands in the 4 visits,
Okay.
and it was 3.25 on the 5. So almost a three to four times increase in the number of
How
meibomian glands yielding liquid secretions in 5 versus 4.
how far out from the initial IPL are you checking that?
So from the initial
Is
is
it at the
for
same
is
time point in both that you're checking it?
No, because we're seeing everybody, and this was a retrospective. It wasn't a
Yeah.
prospective study. So we see most of our patients 4 to 8 weeks, and the sweet spot for us is 6 weeks post their last IPL.
Me too.
And so
Yep.
So the people who have had the 4 visits, we're seeing them closer to their first visit, whereas we're pushing it out a little bit further,
I'd
obviously
be
because
curious if you looked at them at the same time point in time as
hmm
from as far as because we know that there's a cumulative effect and we know that it is
Yep.
kind of over time. Now, I wouldn't expect that it would be that much of a difference. The three whole glands functioning, right? Because
Yep.
you said you went from 0.75 to 3.75.
hmm
I wouldn't expect there to be that much of a difference, but
Yeah.
it would be interesting to say, hey, we look at everybody at this exact same time point to see is any of it because of time change and just
Yep.
the continuance of what we know happens, or is it really truly that fifth one? I think it's probably really truly that fifth one, but
There could be some
yeah,
time in it
yeah,
too. And, there's all sorts of holes in, retrospective studies.
yeah,
And as we look at this, usually when we don't have gland expression, we do thermal pulsation on almost everybody. So the vast majority of our patients do thermal pulsation
yeah,
and IPL.
yeah,
So
which
we
would be
really had
ideal.
to dig in to find the ones who didn't, who had bad gland flow. So it was a smaller sample size because we
Yeah.
really had to find those patients. But it just kind of goes to show that you're very successful with 3. And in our practice, we're finding we're more successful with 5. And I think what that really can do for our colleagues is confuse them and make it so that it's like, I'm
Yes.
not going to do this at all until y'all figure it out, right? But I think what we can say
But
is that
then,
the
like you
vast
already brought it
majority,
up,
yeah,
the devices, that makes a difference.
yeah. And so knowing the device that you're using and
Yes.
in the company and their training, whoever
Talk to
they're going to
them.
bring into your office, they're going to help you with those
Yeah.
protocols. And really it works great. And, understanding what the expected outcomes are going to be really kind of blows it out of the water. And then low level light added on top of IPL,
Yes.
in all the literature that we see, when they're done together, all of the papers show, I think all of them that show that combo treatment shows that it is more successful.
Yeah. You
But
had
it
an
brings
additive effect.
it brings up that thing to you and I is the 2-hour eye exam in optometry school was the best eye exams we ever gave. But can we continue to do that on every patient? Can we do radio frequency, IPL, Tixel, and low level light on every single?
Yeah.
We can't, right? So you
Yeah.
kind of have to figure out what's going to be right for the patient and use the tools
Yeah.
you have, right?
Yeah. Well, yeah. And I mean, you also have to unfortunately think about cost. Costs
hmm
to the patients, these aren't covered by insurance. And as much as I would love to give IPO away for free to everybody, that's not an option.
Right, right. Because you want to get
Although,
paid, right? You
yeah,
want a
I,
check
I
every couple of
I need to
weeks.
pay those bills. But and all of us struggle with that. And I think that we as a group, optometrists, probably have a little bit more of what I jokingly from my childhood called Catholic guilt. Grew up Catholic, we call it Catholic guilt. We're charging people for things. But we do it with glasses with contact lenses. We do it to help our patients, to give them the best opportunity. We just have to remember to, in broaching those things with our patients, that we are offering them something to help, but also making sure it's the right patient. I've had patients come to me who said, I'm coming to you for a second opinion. Someone said I need X, Y, and Z. And I'm like, no, your meibomian glands are fine. That's not the issue. Your issue is tear volume. We need to go
hmm
this direction, right? Now, while I can also argue that is there a person who probably would not benefit from an IPL? Yeah, no, everybody probably would to some extent benefit from having it, but that's not always the best course
Yeah,
of action. So,
yeah. True, true. Well, cool. Well, what I'm hoping everybody walks away from, to recap, is that these light therapies are probably something that you should bring into your practice in 2026. It's a great addition to an ocular surface
yeah,
disease practice. Are you going to be busy enough doing it? Well, probably the first year you're going to get a lot of patients. And I would say the great thing about IPL is that there is not a disposable. And so if you're
yeah,
saying my
that's
patients
really
can't
nice.
afford it, it really is because you're charging too much. So find the right price point. And for some people, it might be, 500 per treatment. Some people it might be 300. Some people it might be 200. But
Depends on where
your
you're
your
at.
return on investment is going to take longer to get there, but it is something you can bring in as an option. And then, you have your team. If you're not good, because you've got Catholic guilt, as you just said, if you have that, have somebody on your team help convert the patient. You tell the patient what they need, and then have somebody help make that conversion and find somebody in your practice that's really good at it. But whether it's low light level therapy, whether it's IPL, and we can talk about all the others, but this is a good year to shed some light in your practice, don't you think, Doc?
I think it is, no pun intended.
Yeah, yeah. Well, thank you for hanging out with me on the podcast. It's such a pleasure to get to chat with you.
Absolutely, always. Thank you for having me.
Yes, and thank you for listening. Make sure to like and subscribe. We'll see you next time on the OI Show.